Dr. Rukaba with care of the patient with hematological conditions. The first condition that I'll be discussing is sickle cell disease or sickle cell anemia. This is considered an autosomal recessive pattern inheritance. It occurs in people of all races or ethnicities. However, 1 in 365 Blacks or African American are affected by it, and 1 in 3 Blacks and African American are born with the sickle cell trait, which means that a person inherits one normal gene and one sickle cell gene. They don't have signs and symptoms. However, they can pass it on to their children. So pathophysiology of sickle cell, as I mentioned earlier, is a genetic hemoglobin disorder. What happens is that there is a issue with the shape and the function of the hemoglobin. There's an abnormal hemoglobin chain. So formation of abnormal hemoglobin chains, cells are distorted. They look like a sickle shape, and not only that, these sickle cells, they clump together, and so they block blood flow. And when, as you know, when the blood flow is blocked, then the tissues are not going to be able to get the blood and the oxygen that they need, becoming hypoxic. This is one of the most severe forms of hematologic or hemoglobin type disorders. Now, normally, us that do not have sickle cell, we have hemoglobin A, and that has 2 alphas and 2 beta chains of amino acids. And so the red blood cells have about 98% of that. So that's us normal folks that don't have sickle cell. Hemoglobin S is the sickle cell hemoglobin, has 2 normal alphas and 2 abnormal beta chains of amino acid or proteins. It causes the red blood cells to fall and kind of distort that nice little round shape of the hemoglobin to, as I mentioned, a sickle shape. Again, making things sticky and clumping together. Causes can be related to, sickle cell is the cause of anemia. Pain, disability, organ damage. There's a high risk for infection, and obviously we know that there is a decreased perfusion, and that could lead to death. We are admitting a person, a client, a patient with possible sickle cell disease. We have to conduct our assessment, and part of that assessment is getting a history, doing the physical assessment, and a psychosocial assessment. Now, history is going to give you a lot of information. It's going to tell us about previous crisis and what are some factors that precede the crisis. So what are things that happen that may be the cause of this crisis? You want to know how bad, how critical was the crisis, how it was managed. And also you want to know if this person was exposed to a person that was sick, because their immune system is low. Therefore, they are at an increased risk for infection. With sickle cell, we also want to look at the type of foods that they eat. How much is their fluid intake? Have they been exposed to extreme temperatures? Have they been using alcohol, tobacco, drugs? Are they going through a lot of stress? How's their sleep and rest patterns? Are they fatigued? So again, the history is really important so that we can pinpoint what has caused it, how bad, and how it needs to be managed. It gives us information of what are some of the factors that really, really can precede the crisis. Now, with sickle cell, one of the important aspects of our care is the assessment of pain. And remember that there is reduced or low perfusion to the organs. And so that is going to cause pain. And those folks with sickle cell, pain is a really, really bad problem. Pain is the most common symptom that we see with our sickle cell patients. Now, other things that signs and symptoms or cues that we may see with sickle cell is, they are at high risk for heart failure. That's an important fact. They're going to have fatigue, shortness of breath, anything that you can think of that is the result of low perfusion or low oxygen to the cells and to the organs. You may hear a murmur upon listening to heart sounds. They may have jugular vein distension. That's a really critical type of cue. Extremities cool to touch, slow capillary refill. They may have increased heart rate. Their blood pressure could be normal or it could be low. Respiratory cues, they kind of change over time. And so they can develop a lot of other conditions. Skin, they can have pallor, very pale, or they may have that greenish, not greenish, grayish, bluish type of color. We know cyanosis, jaundice, and the jaundice can be because there is an increased destruction of the red blood cells, and when there's that destruction, it releases bilirubin. Abdominal wise, you may on assessment notice spleen or liver enlargement. So important cues to follow. Kidney, chronic kidney disease, which could lead to kidney failure. Musculoskeleton, they're going to have joint damage, joint degeneration. They have decreased range of motion. Neuro-wise, they may have some changes in mental status. They may have seizures, and they may have symptoms of a stroke. Now, they also have something called acute chest syndrome, and this is an acute lung disease. And what they're going to have chest pain, and they're going to have pulmonary infiltrate, which means that they may have either increased fluid, pus, blood in the lung tissue or to the alveoli. They're going to have increased arm and leg pain, increased respiratory rate, cough, and wheezing. And acute chest syndrome is most experienced by 50% of those with sickle cell disease. This can lead to multiple organ dysfunction syndrome. It can be caused by an infection. So it can be caused by an asthma exacerbation. This can also cause something called priapism, which is prolonged penile erection. So again, there's a lot of information that we need to find out with our patient with sickle cell. Now, usually we do mostly getting history and doing a physical exam, but we also need to look at doing a psychosocial assessment because this is a chronic type of illness. And so with, again, periods of these crises. So we want to know what is their support system? How do they cope with having sickle cell and during these crises? What impact does this disease have on the patient and on the family? You may want to talk to the patient and see if they're depressed, if they're anxious. This is a painful, life-limiting disorder. So you're going to find out if you're able to get the patient to talk, how is this affecting their lives? see for patients that have sickle cell or to confirm the diagnosis of sickle cell. There's blood work, there's imaging, and then there's others. So with your blood work, there's a test called high performance liquid chromatography, or HPLC. This particular exam is going to identify the types of hemoglobin present and at what level are they present. The sickle cell screen and the hemoglobin S, that is basically they're going to be looking for, screening for that cyclic hemoglobin, or they're looking for abnormal red blood cells. Now the sickle cell screen and the hemoglobin S is screening that is mandatory at birth, and they usually also do it during prenatal care. Other types of diagnostics is your imaging. There's x-rays, CAT scans, PET scans, and MRIs. And for example, a skull x-ray can show damage on the bone surface. It can also show organ changes. And other diagnosis is your EKG or ECG, where it could look for cardiac infarcts, tissue damage, and cardiomyopathy, where we would see an ejection fraction that is decreased, probably less than 30, well, less than that. And that is a picture of your cardiac output. Get our health history, and we do our physical exam, our psychosocial exam, and those diagnostic testing that I just presented. Then we're going to look at those cues. What information are we getting, and what is the priority? Because once we get those signs and symptoms or cues, we're going to look at them and we're going to analyze them and say, okay, what is the priority of care? What are some of the things that are at most important that this patient needs? And so we look at pain. And as I mentioned earlier, pain is a priority, the management of pain for this particular patient. And then we also, because of their decreased immune system, we want to protect them and prevent infection, which can lead to sepsis, which could lead to multiple organ dysfunction syndrome, and can lead to death. So these are the priorities. This is what we're going to base our care on for this patient. Now, this is important to have your interprofessional collaboration. So again, we're going to have the doctor obviously involved in the care, the RN, we may have a cardiologist, a hematologist, the social worker, definitely, case management, respiratory, dietary. And so again, this is not just the nurse taking care of the patient. The care for this patient is going to involve a multitude of disciplines. Two priorities that we looked at in the previous slide. Okay, so remember pain. Pain is one of the priorities that as nurses we're going to need to manage. So how do we manage pain? Well, there are different ways in which we could manage the pain. One is definitely drug therapy, and these can be IV analgesics that can be given IV push or can be given through a PCA. And there are two major IV medications that are given for managing the pain, and one is morphine sulfate, and the other one is hydromorphone. Okay, hydromorphone, hydromorphone. Also, the patient can have some oral doses of opioids and NSAIDs, or your non-steroidal anti-inflammatory disease. There's a medication called hydroxyurea, and this medication keeps the blood cells round and flexible so they can flow better through the vessels and be able to deliver oxygen to body more more easily. Now, there are some adverse reactions with hydroxyurea, and is that it may cause immunosuppression. So when the patient is on this medication, they're going to be doing follow-up regular blood testing. Now, there's another medication. It's called L-glutamine, and it prevents complications of the sickle cell, such as oxidative stress, which contributes to the breakdown of blood vessels. It can cause vascular occlusion and can lead to ischemia. Now, there's another medication, and I'm going to spell it because it's a very unusual the way it's spelled. It's Crizanlizumab, and it's used to decrease the number of pain crises. These are monoclonal antibodies. It prevents blood cells from sticking to the inside of the walls of the blood vessels. Integrative therapies. These are therapies that the patient can use, not only that we can use in the hospital, that they can use at home, but for us, for nurses, in order to keep the patient comfortable, there are some things that we can do. Very simple things like keeping the room warm, using distraction, maybe teaching the patient about meditation, positioning, okay, making sure you got plenty of pillows and that you can reposition them so that they're comfortable. And for those joint pains, maybe some more compresses. Now, hydration is it's kind of like another major nursing priority, because that also contributes to the pain, is making sure that they have adequate fluids, whether it's via an IV. Also, keeping strict INO, encouraging them to take by mouth, try and see what kinds of things they like to drink. So the important thing is that really to increase their hydration. Now, in regards to preventing sepsis, MODS, and death, obviously it's preventing. That's the main thing, that we want to prevent it. So remember in the last slide, they have an increase for infection, and if that infection is not taken care of, it can lead to sepsis, and then the MODS, and even to death. So again, early detection of the disease, preventing infection, obviously decreased immunity, there's damage to the spleen, and so there is that increased risk for bacterial infection for this patient. Hand washing, wearing a mask in the patient's room, using strict aseptic technique for any type of invasive procedures. And and this goes for not just for us nurses, but we're teaching this to our patient, and we're also trying to teach this to any type of visitors that come in to see our patient. And the patient or the nurse can restrict visitors if that's what the patient wants and feels comfortable. Monitor blood tests, especially the CBC and their differentials. Now remember, CBC's white blood, complete blood count has your red blood cells, your white blood cells, but within your white blood cells, there are different types of white blood cells, and those are the ones that kind of appear when there are different types of inflammation or infections in the body. Maintaining or obtaining vital signs, checking the mouth for lesions, checking breath sounds, maintaining like a strict INO. How much are they urinating? What is the color? Does it have an odor? And as far as preventative, we also want to encourage the patient to get the pneumonia vaccine, COVID-19 with booster. And another thing, just for patient comfort is make sure that they remove excessive or clothing that is restrictive. Checking their O2 sets, providing oxygen as needed. And it may be that later on they will need a blood transfusion with the red blood cells to kind of increase that hemoglobin A. Remember I talked about for those that don't have sickle cell, we have hemoglobin A, and those with sickle cell have more of a hemoglobin S, and that's what causes all of these symptoms. And this is a multidisciplinary care coordination and management for this patient, and so we were going to get all of those disciplines that can help with the patient's care and teaching the patient about preventing crisis and complications. Because a lot of times, like I mentioned earlier, things like maybe binging on alcohol, maybe taking drugs, maybe they're under a lot of stress, maybe they were exposed to somebody who had an infection. So we want to make sure that we are covering those types of points to help them prevent future crisis. Now, in the book, in the chapter box 34.2, there is really detailed information about patient and family education prevention of sickle cell. So make sure that you read that. Again, teaching the patient, increasing fluids, avoid smoking, making sure that they're taking their meds, and that they're following up with their primary care provider on a regular basis. This patient's hospitalization, we want to evaluate to see if our nursing interventions worked. And remember that the priority is pain, comfort, and preventing infection, sepsis, and MODS, and even death. So we want to look at those things to make sure that they're back to baseline, basically. So again, this is what we want to see to evaluate, did our interventions work? And disease prevention that requires teaching for this patient is genetic counseling. It can be offered if they want it. This is a genetic disorder and it cannot be prevented. So if we have a female who has sickle cell, it may be, or it's important to have the conversation as to, are you planning on having children? So talk to the patient and talk to them and teach them about different contraceptive choices. Is anemia. And so when we hear that we have a patient that came in with anemia is not it's not a diagnosis. It is an indicator. It's a symptom of an underlying disease. So anemia is low red blood cells, low hemoglobin, low hematocrit. And so there is an impairment of the body's ability for gas exchange. And so when the oxygen carrying capacity of the body decreases, meaning that less oxygen is being transported to the tissues and the organs, this is going to create added demands to other systems, such as your pulmonary system and your hematological system. Now, causes, there is dietary problems, and this relates to like iron deficiency, vitamin B12 deficiency, and folate, some genetic disorders, some bone marrow disease, and excessive bleeding. And so we're going to look at these individually. These are general cues or signs and symptoms of anemia. And I kind of organized it in kind of like systems of the body. So for how anemia affects, or what do we see in terms of skin, the patient will have skin's going to be cool to touch. They're not going to tolerate cool temperatures. They're always cold, and their skin is going to be pale. They may have that ashy type of look. Cardiovascular wise, they may have increased heart rate or tachycardia, and that's because the heart is working very, very hard and fast to make sure the blood is flowing to meet the demands of the tissues and the body. As far as respiratory, there will be a decreased O2 sat. The patient is going to kind of be short of breath on exertion. They're going to have a lot of fatigue. It's really going to be hard for them um, to be able to perform activities of daily living because of this breathlessness on exertion. GI symptoms, the patient will, they can have anorexia, they can have diarrhea, glossitis, which is inflammation and swelling of the tongue. That's particularly common with your vitamin B12, and I'll go over more of those in a minute. They can have nausea, and they can definitely have weight loss. Musculoskeleton, they may have difficulty walking. Neuro, again, fatigue. They may have numbness in the hands and feet, and reduced energy level, as I mentioned earlier, with shortness of breath on exertion and fatigue. Now, things like numbness in the hand and the feet, difficulty walking, you probably are saying those are severe symptoms. And so if the patient's having those kinds of symptoms, we know that their anemia is pretty severe. Here's a discussion on the different types of anemia. Please make sure that you're taking notes. Iron deficiency anemia. There is iron missing. This is very common types of anemia, especially with your premenopausal women or women of childbearing age, women that have their menses. It can be caused by several things. Blood loss, which happens with your premenopausal women. There may be that there is decreased absorption of iron, maybe inadequate intake of iron in the diet, alcoholism, a partial gastrectomy or a surgery that removed part of the stomach, pregnancy because the fetus is now depleting mom's iron reserves, adolescent, as I mentioned, and infection. B12 deficiency, also known as cobalamin deficiency, it can be due to dietary deficiency. It can also be related to the stomach's ability to absorb vitamin B12 and folate, which we know as pernicious anemia is an autoimmune disorder. And what happens is that it is causing the stomach, it's missing what we call the intrinsic factor. And so with the intrinsic factor missing, the stomach is not able to absorb vitamin B12 and folate. Causes similar to iron deficiency, partial gastrectomy, alcohol, but with B12, there are some drugs that can affect the absorption, which are your oral contraceptives, your anticonvulsant or your seizure meds, and cancer meds. Another cause of this vitamin B12 deficiency may be related to the bone marrow producing oversized red blood cells, and this is known as megaloblastic anemia. Just because the bone marrow is producing oversized red blood cells does not mean that because it's bigger, it can deliver more oxygen to the cells. No, oversized red blood cells is abnormal. So with B12 deficiency, you're going to see some of the general types of symptoms or cues, but you also see glossitis, fatigue, weight loss, jaundice, and some paresthesia of the hands and the feet. Folic acid deficiency, very similar to B12 because they kind of go hand in hand, except as far as signs and symptoms, we don't see the paresthesia with folic acid deficiency. It can be related to, again, poor nutritional intake, maybe they're not taking their green leafy vegetables, they're not eating liver, citrus. So again, those foods that are high in folic acid, they're not being consumed. There can also be a malabsorption syndrome, especially with Crohn's disease, that again, your stomach and your body is not absorbing the vitamins that you need. Drugs can also contribute to this, anticonvulsive and oral contraceptives. Now, aplastic anemia is considered a bone marrow disease, and this is where the bone marrow fails to produce enough blood cells. And it could be related that there's destruction somehow, there's destruction of the stem cells in the bone marrow, or the person has a history of being exposed to radiation, insecticide, hepatitis B, infection, or even to viruses like your Epstein-Barr virus. Signs and symptoms, dizziness, weakness, fatigue. Treatment for this is blood transfusion, immunosuppressant therapy, and bone marrow stimulants. Then we have hemolytic anemia, which is a malfunction of the immune system resulting in the increased destruction of red blood cells. Because the body perceives the red blood cells as a foreign body, and so it's going to develop antibodies against that. Anemia of chronic disease. This is inflammation caused by chronic disorders that kind of decreases the production of red blood cells or decreases the lifespan of red blood cells. All your cells in your body, they have a lifespan. And so for somebody who has anemia of chronic disease, the red blood cells don't last very long. That's basically it. Or it also can be related of how your body uses iron. And so we see this a lot in our older adults because they are the ones that have the chronic diseases. Patients that have cancer, patients who have chronic kidney disease, patients who have heart failure, or patients who have autoimmune disease. One thing I want to return, anemia related to blood loss. Obviously, the person is losing a lot of blood. It can be due to trauma. So where there's an excessive bleeding and trauma, and this causes decreased red blood cells and decrease in hemoglobin. Causes of anemia, we looked at general cues and some specific cues. So we're going to look at what our interventions are, how we're going to take care of our patients, and what are some of the teaching that we're going to be doing. With your iron deficiency anemia, again, want to increase oral intake of iron, whether it's through food or with iron supplements. So iron supplements, make sure that when you have a patient who is taking iron supplements, that they know that it can be taken with orange juice. It helps with the absorption. Also, make sure that you teach them that their stools may become dark gray or black, and that's normal. Once they're off the iron, then that goes away. So again, there's some things that you need to teach the patient. Also, you want to encourage them, give them a list of those foods that are high in iron, like beef, lamb, turkey, pretty much all your meats and eggs, some of your seafoods, dark green leafy vegetables, broccoli, white bread, wheat bread, oat cereal, bran cereal, raisins, dates, strawberries, prunes, lentil, kidney beans, garbanzo beans. Um, so again, and then also you can also bring in a registered dietitian for any of the types of anemia that are related to um, um, decreased intake. With vitamin B12, again, same thing. Want to give them a list of those foods that are rich in B12, and I'll give you some liver, especially your organ meats, clams, sardines, beef, 4 to 5 cereals, tuna, trout, salmon, 4 to 5 non-dairy milk, cow's milk, eggs. Also, B12 can be given through injection. Their monthly B12 injections, maybe some oral preparation, nasal spray, and there's also sublingual cobalamin. Folate acid deficiency, again, diet high in folic acid and vitamin B12. Anemia, the physician or the team wants to find out what is the absolute cause of the aplastic anemia, related to T cell destruction. The patient may require blood transfusion, and with blood transfusion, there are some nursing responsibilities pre, during, and post transfusion. Immunosuppressant therapy can also be added to the treatment regimen. Bone marrow stimulants like your epoetin alpha. If the aplastic anemia is related to a drug, make sure that that drug is discontinued. I want to chat a little bit about the immunosuppressive therapy. What that's going to do is going to decrease the activity of the body's immune system. And these are mostly given or added as a treatment for candidates that are not that cannot have a bone marrow transplant. And there are several meds, ATG and cyclosporin, which are some of the immunosuppressive medications. So immunosuppressive therapy prevents the immune system from attacking the bone marrow, allowing the bone marrow to, for the stem cells in the bone marrow to grow and to increase blood count. The to hemolytic anemia or acquire autoimmune hemolytic. Again, there are some different severities and types of hemolytic anemia, so I guess depending on what they are will be the treatment of choice. But usually it would be steroids. And as you learn in PathoPharm, when you're giving your patient steroids, there's some nursing responsibilities that go with that. So make sure you understand that. And if the steroids fail, then they will remove the spleen. Anemia of chronic disease, obviously, they want to address what's causing the anemia, and they may need what we call erythropoiesis stimulating agent, like your epoetin, which stimulates the bone marrow. Anemia related to blood loss, you're going to correct the cause of the bleeding and transfusion, maybe some iron supplement. Disorder is thrombocytopenia purpura, and this relates to circulating platelets. So there's a reduction of the platelets that circulate, which causes impair in clotting. So if there is impair clotting going on, then you're going to be watching and be vigilant of the patient having bleeding. There are 3 types of thrombocytopenia. The first one is called ITP, or idiopathic or immune thrombocytopenia purpura. It's an autoimmune disorder in which the lifespan of the platelets decreases by antiplatelet antibodies, meaning your body attacks their own platelets. And so this can cause, this can result in severe hemorrhage. Risk factors for ITP, female between the ages of 20 and 50. Some medications can cause ITP, some viruses, HIV or Hep C, or some other autoimmune disorders. Signs and symptoms or cues that we may see is easy bruising or purpura, which is areas that look purple. What are some of the labs that are used to diagnose? Is hemoglobin, hematocrit, platelets, and because you may be transfusing, there's usually type and cross that's gonna be tested as well. Treatments for ITP is corticosteroids, immunosuppressants, and maybe removal of the spleen. So remember, review the functions of the spleen so that you have more of an understanding why sometimes the spleen has to be removed. The next type is TTP, and this is your thrombotic thrombocytopenia purpura, TTP. What happens here is that platelets, they clump together, resulted in, there's not enough of the circulating platelets. This is a condition that can be acquired or it can be inherited. Risk factors for TTP can be other autoimmune diseases. What are some of the diagnostics? CBC, type and cross. What are some of the cues or signs and symptoms? We're going to see that purpura. We're going to see pallor. Patient's going to complain of weakness. They may have fever. They may have some blood in their urine or red blood cells in their urine. And the treatment for this is what we call a plasma exchange, where they will give you some fresh frozen plasma. They can also give some antiplatelets and some medications as well. And then we have the HIT, or the HIT, which is heparin-induced thrombocytopenia. And for some reason, it can happen when a person is receiving heparin, which is an anticoagulant. It can happen up to 2 weeks after the patient has had heparin. So there's an unexplained decrease in the amount of platelets, and it's an adverse reaction to heparin. Risk factors, as I mentioned, receiving heparin therapy up to 2 weeks, being exposed to heparin while in the hospital. Female is also a risk factor. What are some of the diagnostic or labs? ProTime, INR. The treatment is to stop the heparin and give them anticoagulants that are not heparin type. There's some new ones on the market that can do that. What are the signs and symptoms? The patient's going to have swelling of the extremities. They're going to have pain. They're going to have redness. So whenever you have anybody on heparin or any type of medication, you always tell them to let you know if something doesn't feel right, and listen to them. R is going to be on transfusion therapy. As nurses, we are going to be giving a lot of, we're going to be transfusing a lot of blood products. So it's important that you are comfortable with transfusion blood and blood products. There's different types of transfusions. So you will get an order for a patient to have a transfusion, and it can be specified, you know, the patient to receive 2 units of red blood cells. And this can be somebody who lost a lot of blood during trauma surgery. A lot of your ortho patients, they will get blood transfusions because ortho it's really bloody. I mean, they lose a lot of blood um, in surgery. Also, it can be due to anemia or any type of blood disorder. There's also transfusion of platelets given for low platelet count, which platelet counts that falls below 100,000 cubic millimeter is going to call for platelet transfusion. Sometimes is given with if the patients have an invasive procedure or if the patient's having chemotherapy. Plasma transfusions, it's going to replace blood volume, and is also going to replace clotting factors, and it's also going to provide some immunoglobulins or antibodies. So you will probably see an order that says, please infuse so many units of FFP or fresh frozen plasma. Okay. And this can be given for somebody who, with severe burns, sepsis, liver failure. So this is a reason why for plasma transfusion. The next one is granulocytes or white blood cell transfusions. It is given to treat life-threatening infections, but I really haven't seen any patient in my career receive that. So, but who knows? You may be one of the folks that are going to be transfusion white blood cells. And then we have something called massive transfusion protocol. This is given for severe blood loss related to major surgery, trauma, obstetric hemorrhage. And this is the administration of 10 units or more of whole blood or packed red blood cells within 24 hours. And this is to restore volume, to increase clotting ability, and also to increase oxygen carrying capacity. Now, whenever, depending if you're on the field or in the hospital, there's going to be protocols. So make sure that you follow your hospital's protocol in regards to massive transfusion, because they may, there's some protocols that they will give different types of blood products. For example, they can have a protocol of 1 to 1 to 1, meaning 1 unit of blood, 1 unit of fresh frozen plasma, and 1 unit of platelets. And so, you know, that will vary how much of what type of blood is going to be given. Okay, so that is your massive transfusion protocol. Patient has an order for transfusion. Again, review your hospital's policy so that you follow, and it will tell you step by step what you need to do. Now, there's going to be an order, transfuse 2 units of packed red blood cells over 2 hours or over 4 hours. Now, your blood products have a limit, excuse me, before they start hemolyzing. So I think packed red blood cells, you can infuse them between 2 to 4 hours. Okay, but make sure that you're following your hospital's policy. So that's going to be order, or there may be an order that says, please type and cross for 2 units of packed red blood cells. And then when it's type and cross, then the blood bank will say, hey, we have blood ready for so-and-so. You're going to verify the order with another RN. and you're going to pick up the blood, or at least that's been my experience. You go to the blood bank, you pick up the blood, and when you're there picking up the blood, you have information about your patient that you are comparing with the information that the blood bank has, and it has to be a match. So again, tested donors and recipients, blood for compatibility. Again, using your two identifiers for patients to receive transfusion. Once you bring, again, that's when you're bringing the blood back up to the unit. You're going to start the blood. You have to verify with another RN using the two identifiers. You're going to look at the bag. There's labels and labels and tags that you're going to leave on the bag. Okay, so you want to check the blood for expiration date and time with another RN. It's always everything that you're going to be checking before you start the transfusion is going to be with another RN. And you're going to inspect the blood for discoloration, gas bubbles, cloudiness. Now, before you hang before you even go get the blood, if the patient's going to get blood, you want to make sure that you have everything you need, which is a blood transfusion tubing. Okay, blood can be transfused with normal saline. That's the only fluid that blood can be transfused with, normal saline. Okay, normal saline. And so there's tubing, and you're going to prime the tubing with normal saline. And most importantly, you want to make sure that your patient has a good access. They usually say an 18 gauge needle is the best. Yes, it is the best, but sometimes you cannot get an 18 gauge needle IV catheter on a patient. So I think there's some leeway in which what gauge is okay for you to start blood transfusion. If the patient has a PIC, no problem. If the patient has a central line or a port, as long as you verify that it's in the right place by withdrawing and see if you get blood, checking for blood return. That there is a consent, obviously, the patient has to consent to receiving blood. Administer blood product to the appropriate filter tubing because it will remove any type of contaminants that the blood may have. As I mentioned earlier, you want to infuse blood products only with IV normal saline because any other may cause breakdown of the blood cells. Okay, so you got your primed your tube with normal saline. You got the blood. You got the blood running with the IV. Oh, even before you go pick up the blood. Okay, and this is best. Before you pick up the blood, get a set of vital signs. All right, if the patient has a fever, you need to report it to the doctor. And the reason why I tell you to get it before you go down and get the blood is because once you have the blood is out of the blood bank and it's on the unit, you have a certain amount of time to transfuse that blood. Okay, and if the patient has, let's say, a fever or blood pressure's high or something's going on that they want to hold the transfusion, you've already removed that blood from the blood bank. So again, kind of be proactive and get your vital signs before you go down and get the blood. Okay, all right, so once you have the patient all set up and consent signed and you have the tubing, you have the saline, everything's going great. You want to stay with your patient for the first 15 to 30 minutes because this is the time where the patient can have a severe reaction. All right. While you're in there, talk to the patient, do some charting, but you want to make sure that you're with the patient. When you're infusing blood, it has to go at a certain rate. You don't want it to go too fast. You don't want it to go too slow. And so when I first started in nursing, we would have to count the drops, kind of eyeball. so that the blood can infuse at a rate that it's supposed to. Now the blood can be given through a pump because there's special tubing now. Monitor vital signs as often as the policy says. It's usually every 30 minutes. And make sure that you are cognizant of what those vital signs are. Remember, I said you want to hang out with your patient for about 15 to 30 minutes after you start the transfusion, because that's kind of the length of time or the time period where if there's going to be a blood transfusion, that's when it's going to happen. However, there still can be a blood transfusion reaction within 24 hours of being transfused. And there can be a delay reaction that can take up to 30 days. That is new information for me. And so the patient can have a febrile blood transfusion reaction, a hemolytic, an allergic, or a bacterial blood transfusion reaction. So some of the symptoms that if you ever witness, the patient's going to be complaining of itching. They're going to have the hives or urticaria. They're going to complain of fever, chills, nausea, chest pain, lower back pain. They may have dark urine. Okay, so you're with the patient, everything's going great, and he starts complaining, okay? That something doesn't feel right. You get vitals, his temperature goes up high, his heart rate is high. So what are you going to do? Well, you're going to stop the transfusion. Okay? You're going to stop the transfusion. You're going to remove all the blood tubing, return the bag and the tubing to the blood bank. You're going to call rapid response. You're going to get another access where you can flush with normal saline. Or if you cannot find another access, flush, that access with normal saline, provide oxygen. You may have to give them Tylenol. You may have to give them Benadryl IV. If the patient gets really, really bad, be ready to do CPR, to monitor, or maybe transfer to the unit. But there's in my experience as a nurse, I've never had a patient that had a transfusion reaction. And it is because of all of the protocols and all of the steps that is taken to ensure that to prevent those acute transfusion reaction. There are going to be times where you're going to be doing an autologous blood transfusion. And what that means is that you are infusing the patient's own blood. And this is very common. Patient decides, I'm going to donate my blood. And so they collect the blood preoperatively. So the patient goes to the blood bank, he donates the blood. And depending on how they're doing during surgery, because they're monitoring their H&H, they may give this blood transfusion during surgery, or it can be given after surgery. Now, years ago, I don't know whether this is still going on, but when I worked in ortho, the blood that the patient was losing during surgery, that was collected, okay, in a special device, and it collected, it filtered, and it drained the blood in a bag, and then that blood was reinfused into the patient. But again, many patients will go to the blood bank and they will donate their own blood. It kind of reduces the risk of transmitting bloodborne diseases or eliminates compatibility issues. So again, autologous blood transfusion is giving the patient's, transfusing the patient's own blood. Let me know if you have any questions.